an injury. So why do they have chronic pain? And of course they go to their family doctor, whoever, and it's arthritis, of course. That explains everything, apparently. I think it's ridiculous that that gets pawned off as an accurate diagnosis, which is pitiful, because most healthcare providers know zero about body mechanics. And this affects every single person out there. So that's what we're going to talk about. And again, this may be a little out of your wheelhouse, but these are important issues in our health and our lives and our well-being, quality of life for every American. Oh, no. There we go again. There you go. So what is gait? Gait is the study of how the body moves and walks. An incredibly complex topic. Every time you take a step, there are thousands of changes occurring in how all the bones are positioned. And this isn't the foot, though. Please, this is not isolated to the foot. We're going to be talking about body mechanics because the foot is hooked up to the leg. I could sing the song for you. Would you like that? Foot bones connected? No, but it is so true when it comes to the kinetic chain, the relationship and interaction of all these different structures with weight bearing. This is a critically important part of the discussion of the kinetic chain because, you know, you got your foot up in the air on the table or the chair or whatever, and you move the foot up and down. That's all that happens. The foot goes up and down. But when you have the ground under the foot, that changes everything. And how things move and interact are going to be completely different when weight bearing. And that's when these problems develop. So we're going to be talking some about that. And by the way, I'm supposed to mention that some of you have handouts on the lecture. It's all been jumbled and moved, and I apologize. And great, great. So I'll try not to lose you. Okay. So an important part of this discussion is the repetitive nature of gait. 10,000 steps a day, 365 days a year for however many years. And so any little abnormality in architecture or function is going to be exaggerated step after step ad infinitum, et cetera, et cetera. So that's an important factor in the development of many of these problems. And we'll talk some specifics, but I do want to try to get into a little bit of the basics of biomechanics. But again, second paragraph talking about when weight bearing, things move differently. So that really changes the whole discussion, but does allude to the fact that what the foot does, how the ankle moves, the arch, all these tendons and structures all have to work together. Nothing in the human body operates independently. And when it comes to gait and body mechanics, this is absolutely the case. And many foot problems, ankle, whatever, is going to cause problems elsewhere. So many Americans with low back pain have problems with biomechanics, and that's why they have pain. It's not arthritis. So the two basic motions of the foot, pronation and supination. We got some runners out there. They probably are familiar with these terms because this to some degree determines what type of running shoe you have. So that's why they're interested. But basically, to simplify it excessively, and it is a complex process, but every time you take a step, the foot is pronating and supinating. And pronating is when the arch rolls down. So pronation is a motion. Supination is a motion which the arch raises up. Now, you could have a foot that's pronated, which means it's in an excessively collapsed position. So there's position versus motion. So we'll talk. And so part of those pronations, supinations, where the foot is dorsiflexing and plantar flexing. These are the three motions involved in pronation and supination, the basic motions of the foot. Again, there's millions of variations on this, but as a concept. So again, natural motions, you need both of them to walk in a healthy fashion. So again, it's important to understand pronation and supination are normal motions. and then versus position. But in nature, too much of anything is a bad thing. And this is such an interesting concept. And I don't think it's by modern healthcare really appreciated and acted upon. But especially when it comes to biomechanics, we need balance. That's what nature needs. Not blood chemistry that's too acidic or too basic. Nature likes a balance, kind of in down the middle of the lane. So if you have, for example, an arch that's too high or an arch that's too low, you're going to have problems. If you have a foot that's too twisted or too straight, it's going to alter your biomechanics. So a huge part of this discussion is your anatomy, your skeletal structure, your tendinous structure, how everything is balanced and arranged and working together. And by the way, when it comes to biomechanics, there is so much, as in medicine in general, there's so much we don't know. You know, it's hard to study these things in a living person, and we do cadaver studies, but they're all manufactured and altered, and it's not natural or the normal situation. So the tendons, you have tendons on each side of the foot. The tibial tendons running to the medial aspect, the peroneal tendons to the lateral, they've got a balance. And if your skeletal structure is such that things roll down too much, some tendon or some structure, ligament, whatever, is going to be stressed. So the soft tissue stress theory. Now, this is a theory, but this has really become more and more prominent and has really credited for explaining many of these problems. The idea is that any structure which is repeatedly, excessively, physically stressed will become diseased. And with disease, inflammation, pain, these kind of things develop. Now, inflammation is a whole other topic. I'm going to stay away from that because we'd be here for days. But any structure chronically inflamed will cause pain eventually. It's just a matter of time, which is why so many of these problems, shin splints or heel pain, or again, there's a plethora of options that are of structures affected by these problems. Why so many of these problems develop when we're 50 or 60 or 70, and clearly not due to an injury. So you got to ask yourself, why is this pain develop? Never had it before. I hear that every day. I didn't have this pain before. You've never been this age before. Seriously, things develop. In medicine, everything changes. And in health, as far as the human body, obviously, we all know time has a tremendous effect on the human body. So, let's be realistic here. We can't escape time. So, foot architecture, which you inherit, of course, you can blame your parents, it's easy, is responsible for a lot of these problems. So again, if you've got an arch that's collapsed, that might cause problems, but not necessarily. So again, a lot of complexity here. A big part of this is joint congruency, how well seated are the bones involved in any joint in the foot or leg. But any deviation from normal is probably going to cause some kind of problem. Now, it could be a severe problem, it could be extraordinarily painful, debilitating, or it can be a minor nuisance. So many, many variations on this. But in biomechanics, function follows form. So how things work really are dependent on how they're structured. And this is not just skeletal structure, not just your bone structure, but the tendons and ligaments and nerves and all these other structures. So any chronic physical stress will lead to inflammation and pain. Pronation syndrome. Ooh, now we got a syndrome. Basically, this is where the arch rolls down excessively with every step. And so I hope you can see the consequence with time. So biomechanics and time are intimately connected. But specifics of pronation is where dorsiflexion, the foot's coming up. That's a minor part of pronation. It's much more, less sagittal plane changes, much more transverse and frontal plane changes. But abduction is where the foot moves away from the midline of the body, and eversion is where it turns out. The bottom is everting to the limb. Whoops, did I? Yeah. Okay. So, did I skip a slide? No. Okay, I got that. There we go. So what causes poor biomechanics? Huge variety of things, some of which probably seem obvious, your bone structure, but some of these are not obvious. Tarsal coalition, that's an abnormal union between two bones of the rear foot. Clearly is going to alter how things work. A tight heel cord, a tight Achilles tendon, we'll talk a little bit about that. I'll bet you a majority of this population has a tight Achilles tendon. A tight Achilles tendon is the cause of a multitude of musculoskeletal complaints, some of which are very serious. And that's really a function of the fact that most of the shoes that you people are wearing have a positive heel. The heel is higher than the ball of the foot. The vast majority of the shoes sold in America have a positive heel and encourage the shortening over time because it's a tendinous structure and it will adapt to the length that it is asked to run or forced to run. So trauma, injuries, lots of things can alter how we work and how we stand and walk. So we're going to talk some specifics here. What are some of the problems that probably a lot of your patients have, and I'll bet you a lot of people here have? Plantar fasciitis, oh man. Probably a majority of the people here today, if they don't have it now, they've had it in the past or will have it in the future. It's that common. Posterior tibial tendon dysfunction. Again, these are things we'll talk more about. Wait a minute, I missed something. There we go. Tarsal tunnel syndrome. Actually, I talked about that this morning. Achilles tendonitis. So let's get into some specifics here. Plantar fasciitis, epidemic. 3 out of every 4 Americans at some point in their life will have plantar fasciitis. That's a majority, and that means this is, and it's just so funny. I mean, people that come in for whatever, a toe problem, and they say, this is my chief complaint, and you go and there's a maneuver where you can isolate the plantar fascia and you push on it and they jump out of the chair, and I said, clearly that hurt. Oh yeah, my arch hurts all the time. Well, you know, there's things that can be done for it. In fact, dare I say, no one has to suffer from plantar fasciitis. There's a solution for everybody. And typically, rarely is it surgical. So please don't think that if you have heel or arch pain that you need surgery. That's rarely necessary. It does vary tremendously. Some people will, there are a lot of people with plantar fasciitis. They're crippled. They cannot try walking without putting any weight on your heel. Let's see how well that works. Because some people this can be a really significantly painful problem. And then for every one of those, there's 5 who have a slight subtle aching in the arch at the end of a really active day. Or if they go for a walk with their 10-year-old walking shoes. Hello, people, please. Shoes age just like people do, only faster. And the problem is a lot of the running shoes, walking shoes, sports shoes that people wear, they don't have the lifespan of a good old leather work boot. Your shoes age. The primary material used in running shoes these days is EVA, ethyl vinyl acetate. It's got little microscopic bubbles. But those leak out over time even if you don't use the shoe. Our shoes age even if you don't use them. Isn't that weird? Again, a lot of people only have pain in the morning, or it can be experienced as a burning, sharp. I mean, the multiple varying symptoms are noted. And no, I'm not even going to try to get the pointer going here. But you can see our nice little bone spur. And so this is such a common occurrence. I get a kick out of this, although it's not funny, it's sad. But they go to their primary care doctors. They can solve anything, right? Right? I mean, people will go to their primary care expecting a solution to, heart disease or a stroke. I mean, they're important, I understand. But so often you go in complaining of heel pain, you take an x-ray, and there it is, this massive spur. We got to get rid of that, right? Heel spurs, let me be specific, spurs on the bottom of the heel bone, the calcaneus, do not cause pain. 99% of the time, we'll take an x-ray, somebody's coming in for whatever, a toe problem or something, massive heel spur. Never had a day of heel pain in their life. So the spur is not a weight-bearing structure. Now, 20, 30 years ago, someone had surgery for plantar fasciitis. We'd go and remove the spur. You're right there. What the heck? Caused more problems than it was worth, and it had no effect on their pain levels before or after. So now it's an incidental finding. It's better recognized and does not need to be addressed when treating plantar fasciitis. And we'll talk about some surgical options, but they don't include removing the spur. But as that last bit there, sometimes plantar fasciitis just disappears on its own. So it's really incredibly unpredictable, although an extremely recurrent problem. Very, very common where it comes back. And then it'll go away for a year and come back terribly for half. It's just tremendously variable. So there we got, there's our weight-bearing spur, non-weight-bearing spur, I'm sorry. But it's basically a strain of the fascia. Now, this is your arch ligament. It helps to support the arch. Very important function in weight-bearing and gait and such. But it's not actually, it's such an interesting structure because it's not a ligament, it's not truly fascia. What the heck is it? It's the plantar fascia. It's its own unique entity. We talked about that. So because it helps to support the arch, how the arch works, too high, too low, flattening, whatever, is typically the primary etiology or cause for plantar fasciitis. It's composed of 3 bands. The medial band is the one most commonly symptomatic because the arch of the foot medially is higher. So this is really a lot of geometry and dynamics involved. So we talked about it. Now, interestingly, any soft tissue structure, like a ligament or fascia, that's chronically stressed will become diseased. And that can cause inflammation, which can cause pain. But interestingly, plantar fasciitis is not specifically a problem with acute inflammation. Chemical studies of the fascia has shown that it's more of a condition rather than inflammation. Fasciosis, a condition of the fascia causing pain, is actually more of the issue than acute inflammation. But again, any of these abnormalities from perfect, normal architecture and function will typically stress some structure, and the plantar fascia is one of the most common, no question about it. But like I talked about, the reasons are multiple and can be something as simple as the surfaces you walk on, body weight, again, shoes, things like that, really common. So let's talk about adult-acquired flat foot deformity. It's more common than you might realize. It is an extension, in a way, of pronation syndrome. You know, it's just a worsening of this alignment problem in which the posterior tibial tendon has become stressed over time and kind of gives way. Now, it's not a rupture, but a process where the fibers, it becomes scarred in and weakened and lengthens. And so it allows the arch to collapse, or is it that the collapsing arch stressed the tendon? One or the other. That's different theories on what's going on there. But this is a progressive problem. People will, with this problem, and it's often unilateral, just on one side, but they'll see where their arch is collapsing down. And typically after a shower, you see your footprint on the bathroom floor, and that's how a lot of people diagnose, an acute flat foot deformity. And it can be acute, though. It can be just one step, bang, your arch goes down because that tendon has ruptured acutely and allowed your arch to just collapse down. It can be quite dramatic. But as I was referring to a moment ago, there is some debate. Is it that the skeletal changes occur because the tendon is diseased, Or does the skeletal structure collapsing put excessive stress, again, the soft tissue stress theory, on this tendon and allow and cause these disease changes of the tendon? And the consensus seems to be these days more towards the skeletal structure and your mechanics stressing that tendon, and the tendon's just succumbing to these forces. Kind of a natural process, expected process almost. And again, we can intervene in this process and prevent some of these changes. So biomechanics, when addressed properly, are great for prevention. What a concept. Let's prevent a problem. What an idea. Why doesn't somebody recommend this in healthcare today? Not so. A stiff big toe joint, hallux rigidus. Hallux is the big toe. Rigidus, it becomes rigid. This is an incredibly common problem, although many people at points in this process, and this is can be a very long, gradual, progressive condition in which the first metatarsal phalangeal joint isn't moving properly. This is a really unique joint to the body. There is no other joint that works with the same mechanism of motion. It's a ginglymus joint, so there you go. I'm sure you needed to know that. But if the first metatarsal isn't able to plantar flex or lower sufficiently, then the big toe, the base of the hallux, the proximal, is going to jam into the cartilage, into the joint, and that repeated jamming process leads to joint disease, thinning of the cartilage, bone. Hey, if I had a pointer, I'd point out this spur, but we don't need a pointer. But early on, at phases, people will have symptoms. It can and often does progress. Again, these are progressive problems. If you don't intervene in this process, we know where it's going. It's very predictable. How much pain they'll have, no, that varies person to person, and so many factors involved there. But we can intervene in a process like this and prevent the spurring, the degeneration of the joint. And by the way, it's not arthritis, okay? Well, in a way it is, because arthritis simply means inflammation of a joint. There's no diagnosis arthritis. Osteoarthritis, sure. Rheumatoid arthritis, psoriatic, yeah. But arthritis, that explains nothing. But you can also damage the joint acutely and develop hallux rigidus. Hallux limitus is the earlier stage where the joint is limited. I do a lot of first MPJ range of motion measurements. And you can see these changes on X-ray developing. So we can intervene in this process and save their joint. And I apologize, I should have mentioned that if you think about it, when you walk, there's a point in the gait cycle in which your foot's on the ground and the pelvis is passing over the planted foot and your heel rises up, right? So you can push off for the next step. Well, you're bearing weight on the ball of the foot and the phalanges. And so clearly, the big toe has to dorsiflex relative to the first metatarsal. So if somebody has hallux rigidus, I don't have to see them walk. I know they have altered abnormal gait. Proper gait requires 60 degrees, 55, 62. I don't care what source you refer to. There's different measurements on this, but you need a lot of motion up to walk normally. And a lot of these people develop chronic hip, back, spine problems, also because they physically cannot walk normally. But they're not aware of it. Who analyzes their gait? Who thinks about their gait? Nobody, because you take a step because you've been doing it all your life and you don't think about it. Now, if you get pain when you walk, well, that's different, but people aren't going to know how to walk. They can't mentally change efficiently this process of jamming of this joint. But typically, osteophytosis, bone spurring develops. And so some people call this a dorsal bunion. I hate that term. Please don't use that. Because a bunion is hallux abductovalgus. That's a completely different problem. Yes, it's of the first MPJ. So how can they be different? But it's more of a sagittal plane problem where the big toe can't come up. Hallux valgus is more of a transverse plane where the first metatarsal is moving away from the rest of the foot. But these spurs, you can see from this, a shoe is not going to do well with that bump. That's pretty obvious. The spurs can be quite painful, and people will, cut out their shoes, or cut a hole in little shoe surgery just to try to get pressure off of these, because these can be really uncomfortable. And you can also get joint pain too, as well. So there are multiple areas. The source of pain varies widely. So there you go. So let's talk about Achilles tendonitis. I referred to that early. Very common problem, occurs for a lot of different reasons, but a tight Achilles tendon is certainly a factor. But surprisingly, foot mechanics, how the heel bone moves, because most cases, by far, of Achilles tendonitis occur where the tendon attaches to the foot. So a heel that's moving too much in the frontal plane, side to side, is going to tend to irritate the Achilles tendon. So people, why would getting into an arch support or foot orthotic help my Achilles? Because it's controlling, or should control, heel motion. But bad foot mechanics will commonly irritate that tendon. So this is the largest tendon in the body, has the most force running through it, critically important in knee mechanics, hip mechanics, spine, and of course, foot mechanics as well. And a tight Achilles can worsen hallux rigidus, absolutely commonly can worsen plantar fasciitis, or maybe the primary cause of plantar fasciitis. So if you're asking Dr. Google, who's got the answers to everything, if you have plantar fasciitis, you commonly see Achilles stretches, and that is beneficial. Although, since we're on the topic, I'm sure there's some people who, work out, stretch, stuff like that, fantastic. I got bad news for you. Most people hold a stretch, Achilles stretch, whatever they're stretching, 5, 10, 15 seconds. The mechanism whereby the fibers actually lengthen does not take place for 20 to 30 seconds. So a stretch of less than 30 seconds, you are getting basically no benefit. So I tell my patients, you got to time it. People don't count time accurately. Hold it a minute. But the studies show to successfully stretch out your Achilles tendon. Are you ready for this? You sitting down? It takes per leg an hour a day for 4 to 6 months. I know. I don't like to tell patients this. I try to hold up. No, you got to stretch more, just more. But it's intimidating. I mean, who can do that? So there are those Achilles stretchers. A lot of bad designs out there for Achilles stretchers, but the posterior splint is the better, more efficient design. Because it's a passive stretch, meaning you don't have to work at it. And by the way, as you see here somewhere, I think, there are 2 components to the Achilles tendon muscle complex, the gastrosoleal complex. And one of them, the heavier one, attaches superior to the knee joint. So if you're doing an Achilles stretch, it is a much more efficient stretch if your knee is straight. Now, that can be uncomfortable for a lot of people because their tendon's so tight, and so they may have to do their stretches early on with the knee bent, but with time, it's a process, obviously, of many days and weeks and months. But it can really have a wonderful effect on biomechanics. So it's something I encourage and I measure in most people. Obviously, you can have acute Achilles tendon injuries from sports or something like that. But this is really more of a chronic situation that I'm referring to. Localized pain, inflammation, swelling, typical inflammatory markers, a lot of stiffness. Now, this is one location where a spur absolutely can irritate the tendon. Unfortunately, these spurs are encased in the tendon, and so to get to these spurs, you got to move the tendon aside and reattach it. And a lot of these patients can be resolved with conservative measures. Shockwave, I mentioned Shockwave, wonderful track record in many studies using Shockwave for treating Achilles tendonitis. Great track record. So let's switch gears, talk about tarsal tunnel syndrome, another most of the time biomechanically induced problem. Now, like carpal tunnel, but carpal tunnel is most of the time an overuse injury, just a repetitive motion, typing or whatever. But in the ankle, the tarsal tunnel is the posterior medial aspect of the ankle rear foot region, inferior to and posterior to the medial malleolus. But it's a tunnel, literally, and there's a number of structures in there. So if you have an inflamed posterior tibial tendon, that can squeeze the nerve, or you pronate too much. That can stretch. Nerves are unique structures, like I mentioned, and they do not do well with any physical pressure, physical stress, pulling, pinching, whatever. Again, nerves are a very unique structure to the body, but a lot of different problems will stress that nerve. But this is a diagnosis that's just too rarely made, and there's electromyogram, this is an interesting test. You probably have heard about people having EMGs, and ask them, have you had an EMG? Oh, I don't know. Have you been stuck by needles and electrocuted? Oh yeah, everybody knows that one. That's a memorable test. I hope I don't need that. So a lot of these times, a lot of people with this problem, it'll be misdiagnosed as plantar fasciitis, because typically with nerve problems, you feel the pain where the nerve is going, not where the injury is occurring. That's a pretty common generalization about nerve problems. So the posterior tibial nerve is also a motor nerve, but it is supplying sensation to primarily the plantar surface of the foot. So any pain on the plantar surface of the foot's got to be plantar fasciitis, right? No, unfortunately not. Or fortunately not. I talked about that. Overuse syndromes can cause it. Injuries can do it. But most of the time, it's poor biomechanics. Now, I might as well mention it now. Speaking of wound care, finding an expert in biomechanics. Good luck. And I'll talk more about that, but that's, midfoot pain. That's on the dorsum of the instep, not a medical term, but most people know where the instep is. It's kind of a jamming problem, where the joints, the midfoot joints, first met cuneiform navicular, will, because of a tight Achilles or a collapsing arch or a higher arch, or some variation from normal biomechanics. Healthy biomechanics will cause a jamming and spur development, and these can be quite painful. You can have acute inflammation develop, although much more common is a chronic inflammatory process. We just don't know enough about inflammation, basically. Blood-borne inflammation appears to be a significant factor in many cardiovascular diseases, kidney problems. We just don't know enough about it. But with a chronic inflammatory problem, there's no heat, there's no redness, it's just pain. So yeah, this is fairly easy to diagnose the presence of spurs, but why are they having those spurs? That's the tougher question. And without a background in biomechanics, you're not going to figure that out. These problems, again, that whole concept of nature in balance. The toes are kept straight by a really delicate balance of structures. The anatomy of the toes is incredibly complex. It's just multiple little muscular attachments and tendons and ligaments. Really amazingly, it's like a tightrope act. You got your tightrope walker with his bar, and if you put a weight on one side of his, whatever he calls it, bar, he's going to start to lean. Well, that's what happens to the toes when you alter biomechanics, with a higher arch foot or a lower arch foot. So toe deformities, hammer toes, or where they're moving in the transverse plane. There's all sorts of different things toes can do. Because again, it's a delicate balance and subject easily to altered stress, leading over time to deformity. So you'll see some nasty hammer toes out there, usually in people with poor biomechanics, but it also could be a neurologic problem. I talked earlier about diabetic neuropathy leading to hammer toes as well, again, because of that altered balance of structures. All right, so how do we alter biomechanics? Get a better pair of shoes. Sometimes it's that simple. There are a lot of people out there with pain and are overusing, oh boy, overusing their shoes, and that can lead to problems. So, but it has to be a pretty mild problem for just simply changing shoes to solve it. Yeah, so often these problems are treated with anti-inflammatory drugs, and that's got to fix everything, right? Unfortunately, no. Some of the newest evidence on nonsteroidal anti-inflammatories, when used chronically, as they so often are, seem able to turn an acutely inflamed problem into a chronically inflamed problem. So we are making problems last longer by masking them with anti-inflammatories, whether it's steroidal or non-steroidal. It's, you know, kind of the same process. It's a Band-Aid. And oh, okay, okay. So a lot of people with mild problems go out and try some kind of arch support. And for some people with a mild problem, you know, slightly abnormal biomechanics, a decent arch support can take care of their problem. And by the way, in case you haven't noticed, this is obviously a popular approach because there's a billion arch supports out there. I'm serious. Go to do it. I dare any of you to do a Google search and look through every page and every listing that comes up. You'll be there for weeks. It's ridiculous. But that just reflects how important this concept is, even though it may not, well, you know, some primary care, some orthopedists do recommend arch supports, are aware of the important benefits from improving biomechanics. So, oh, by the way, that's more than a pronated foot, okay? Just so we're clear. That's definitely an adult-acquired flat foot, although, yeah, you know, you can certainly have congenital flat foot. Now, again, just because an arch is lower or flatter does not mean you have a problem or that you're going to have a problem. Walter Payton had flat feet, okay? The runner, Chicago Bears, come on. Everybody knows who Walter Payton is, or you should. So you can improve your biomechanics by stretching your Achilles. Remember, an hour a day per leg but it is so beneficial. Really, everybody will do better if they start stretching their Achilles. It's just without a stretcher, most people fail. It's just not practical thing. Somebody's going to devote an hour or two a day towards this effort. So the stretcher, and you can buy these on Amazon, although there's a lot of bad designs out there, so be careful. Again, thousands of arch supports. There's a lot of junk out there. And please, by the way, don't believe the advertising on these products, okay? There's no truth in advertising. Seriously. I hear people come in and they said this is going to cure my plantar fasciitis. Don't believe them, because it probably won't. But again, with a mild problem, there are some good prefabricated arch supports, and they can take care of a lot of these problems. Shoes are important too, though, of course. The new materials that we have for bracing are wonderful. I mean, these new thermoplastics and carbon fiber materials, lightweight and strong and don't fatigue or deform. Unfortunately, a lot of the bracing done out there, this is for a more severe deformity, is being fit and prescribed, dispensed by O&P, orthotists and prosthetics. And like we talked about wound care, there's a lot of old methods still being employed. So far too many people with these deformities get into a gauntlet brace. Has anybody seen a gauntlet brace? Oh man, it's like a cast that you can take off and on for just the ankle and foot. I mean, it's not a shoe, but they're big and really restrictive and uncomfortable. But, you know, it's probably better than nothing. Muscle strengthening is not going to overcome bad skeletal architecture. Please Don't think that sending somebody with one of these problems to a physical therapist, they're going to be able to strengthen it out or resolve the problem. Great as an adjunctive approach. Absolutely, I do recommend it, but it's adjunctive. It's not going to be your primary solution to these biomechanical issues. So, foot orthotics. Unfortunately, if you look at national studies of the success rate of custom prescription foot orthotics, it's terrible. The majority can't wear them, they hurt their feet, they don't help the problem, they don't work in their shoes, blah, blah, blah. Does that mean that those people can't be treated with orthotics? No, unfortunately it means that as a nation, our ability to treat or to produce successful prescription orthotics is pitiful, pitiful. It disgusts me. I mean, this is something I put so much time and effort into. You know, okay, fine, I'm going to blow my own horn. My success rate with foot orthotics is phenomenal, and so many of these problems can be treated, resolved. People can be active. Foot orthotics are capable of treating, when properly prescribed, so many problems. And you want to talk about a great therapy? Okay, like fixing a fracture, surgery maybe, diabetes drugs for the rest of your life. Orthotics, put your shoes on. How great is that? I'm serious. What a great treatment. Just put your shoes on, with the orthotics in there, of course. But that means getting properly prescribed orthotics, and unfortunately, most people just don't have access to a skilled provider. Unfortunately, podiatry, I'm going to throw them under the bus here, has really fallen in love with the knife. And when all you have is a hammer, everything's a nail. So problems that absolutely should not be treated with surgery are getting operated on, and there is certainly a time and place for surgery. I'm board certified in surgery, but so often it's unnecessary and ineffective and expensive and complications and, et cetera, et cetera. So my evaluation for foot orthotics takes an hour. Most of the time, you go to your chiropractor, physical therapist, they have you step on a pressure plate or you step in some foam, and that's the extent of the analysis. And by the way, those are terrible methods. If you're looking to get foot orthotics and they have you step in foam, run for the hills. Seriously, please, because that's a bad technique. You will not get an effective orthotic. It's really tough. I wish there were better solutions. I wish, more people were. And the thing is that, yeah, we're doing surgery, but without a grasp and a thorough understanding of biomechanics, how is your surgery going to work? Because you're altering structure and therefore function. It's really sad. Anyway. So they can prevent damage. Prevention, there you go, preventative medicine. But too often, people are prescribed an orthotic. Maybe they took a cast, they use plaster. Doesn't mean the device is going to work. Plaster is the most precise method, the most accurate, most reliable, but it's slow, it's messy and inconvenient. I leave the office every single day with plaster somewhere. I cannot escape it. I try so hard to not get plastered, but I had to work it in there somewhere. And by the way, that is my one podiatry joke for patients. That's all I've got. That's it. So the lab that you use, we used to go 20, 30 years ago with the older materials. You go in your back room and whip up a pair of orthotics, which was great, but the materials today last so much longer, and they don't deform, and they don't crack, and it's just a whole better world. But you need a good lab for that, and there's bad labs and good labs, and so that's important too. And some, this really just gets my goat. So somebody goes in, doctor says, we're going to fit you with orthotics. And they use plaster, and they send it to the lab, who takes the positive. They fill the cast with plaster and create a positive, a copy of the patient's foot. And then they go to their library of shells and match it up. Yeah, that looks pretty close. There you go. There's your orthotics. Those are not custom orthotics. I'm sorry. Custom orthotics, it's the material is molded directly to your shell. You're not getting one of a library of shells. And that's another common approach, and it's just not good orthotic therapy. So, I'm going to talk about, I doubt any of you will be doing reconstructive flat foot surgery, but there certainly is a time and place for reconstructive surgery. Now, obviously, this is for really a more severe deformity, long-standing damage to various structures that need to be repaired as well, posterior tibial ruptures, whatever. So you got to be realistic about your goals here, and there's going to be a difference often in what the patient thinks their goals should be versus the surgeon. So this is important to discuss because you could have two drastically different perspectives on what you're going to achieve. But again, relief of pain, being able to walk better, preventing progression of the deformity and the problems, because these are very common, because again, 10,000 steps a day and you're hopefully still on your feet. And an important question, just an FYI, in reconstructive surgery, is the damage so severe that the joints have been compromised and are devoid of cartilage, non-functional, in which case you're doing a destructive procedure of fusing joints. If you catch it early enough and you don't have that damage, then you can do a reconstructive procedure where you're repositioning the bones so there's less stress to the joints and things can function more normally. But by the way, if you are considering this for a patient or yourself or somebody, these are complex surgeries. This is something, and this is true in medicine in general, especially with surgical approaches. This is only best done by somebody who does this regularly. Don't go to your neighborhood podiatrist who's, doing nails and routine care and stuff and have flat foot surgery. The chances are good the results are not going to be optimal because, again, typically these are complex surgeries involving multiple procedures to create a better foot structure, or a non-functional fused but weight-bearing structure. And that's it. Thank you. Questions? Questions, yeah.
What do you think of barefoot shoes?
Barefoot shoes, like minimalist shoes. Okay, I'm getting on my soapbox. So for about 10% of the population, they have structure healthy enough, optimal enough, that they can do well without shoe gear. But 10% is a rather liberal use of the term. I really think very few of us can do that in a healthy fashion, not develop problems. And when the minimalists, those barefoot shoes and stuff came out, so many running injuries developed because we need the support of a shoe. This whole idea that wearing shoes weakens your muscles, that's nonsense. That has been disproven. So for most of us, this is not something, a healthy approach. In fact, the latest is the maximalist shoe, like Hoka kind of pioneered this with these big, massive soles, very stable, wide soles, but good cushioning. So for a lot of people, now, there is no shoe that works well for everybody. Please, like it used to be, oh, you got a flat foot, New Balance. But all the shoe manufacturers have so many models, and you can't do that anymore. But for most people, that's a recipe for problems, guaranteed.
Hi.
Yeah. Anybody?
Question regarding the custom orthotics. So I know the podiatrist that I work with, he gets so frustrated when people come in with non-weight-bearing foot x-rays.
Well, I'm sorry.
Non-weight-bearing foot x-rays. So
yeah.
and then they'll say, oh, yeah, I've already had x-rays. And he's like, ugh. So with the orthotic, if you're being scanned or plaster casted, you're not weight-bearing. How is that the most precise?
You don't need to say any more.
Okay.
But think about it. These are people with structural and mechanical problems. When you weight bear, you're recreating the deformity. Why would you want to do that? So with my plaster casting, I've got them prone on their stomach, so Gravity is helping me position the foot for the optimal position. We know enough about biomechanics and function to know what is the best position for gait and weight bearing and running and skipping and everything. But by weight bearing, you're capturing the problem. How is that going to work? So weight bearing, scanning, pressure plates, foam boxes, trash. Please, if you're looking for effective supports, and that's the technique, and it's pretty absolute. I'm very rigid about this. Those will not be effective orthotics. Period.
So for the plantar fasciitis treatment, what are you feeling is the best, most effective?
Well, typically
The
orthotics, yeah.
The orthotics.
And it's certainly a reasonable approach. And now, finances and healthcare, you can't remove that from the conversation. Orthotics can be very expensive, depending on where you live. And certainly there are some good prefabricated supports that are enough for a lot of people. Now, if you've got insurance that's going to pay for orthotics versus spending, not a lot, but something for a generic device, seems like a pretty easy decision, even if you don't have a severe problem. In fact, every single human on the planet would benefit from having properly prescribed prescription orthotics. Everybody. You may not have a problem, but orthotics, when properly prescribed, help the human body work more efficiently, better alignment, less stress to a host of soft tissue structures. But there are so many treatments for plantar fasciitis. Compounding. Anybody ever heard of compounding? Compounding is the process, been around for decades, where we put various pharmaceuticals into a specialized agent that acts to transport the drugs into the tissues. So this is a great way to get local pain relief or treat a nerve problem. Depending on what drugs are used, we can use a wide variety of very different drugs in the same compound. So I talked about surgical options. So what I do for plantar fasciitis on those extremely rare occasions when my orthotics don't resolve the problem is something called radio wave coblation or topaz procedure. Topaz is the manufacturer, so I don't like to talk about that. But through a bunch of little poke holes in the bottom with a device that produces high-intensity radio waves, we can zap or break up the diseased fascia, and through a process of healing, it gets replaced with healthier fascia. We turn a chronically inflamed structure into an acutely inflamed structure because acute inflammation is part of healing. This whole thing about inflammation bad, that's part of healing. Now, acute versus chronic are drastically different problems, but I kind of digress there.
That night splint that they advertise, is that something that's effective?
Don't wear it at night because you're asleep and you're gonna bend your knee, and it's a much more effective stretch when your knee is straight. So that's something I tell people. But absolutely, stretching out your Achilles will directly take tension off your plantar fascia, and for some people, not a majority, but some, simply stretching their Achilles will resolve their plantar fasciitis. So many things we can do for. Something I'm doing a lot for plantar fasciitis are regenerative techniques. This is going to change healthcare in America as we know it. Or I take it back, it should. Because it's instituting healing rather than masking the problem with a drug or anti-inflammatory or numbing agent or whatever. So regenerative techniques are wonderful. But they don't involve pharmaceuticals, so why would we encourage that? Anyway, anybody else? Yeah.
Are there exercises or stretches that can correct hammer toes?
No. And there's no brace, little toe brace pulling the toe or bunion brace. Yeah, why do you got and a lot of us try walking or wearing a shoe wearing those. That's got to be uncomfortable. But that will not provide permanent correction. Now, you can kind of stretch out like with a bunion, do some stretching exercise and relieve some pain. That will have no effect on the deformity. Those will not correct these structural deformities. So, have I said that?
How are the power steps?
Power steps?
Yeah.
They're as prefabricated generic supports. Now, but they got a lot of different models. But the most popular one, that's a decent generic support. Yeah. I've seen a lot of people with those. Yeah.
Thank you. So when you're talking about biomechanics and just fixing with gait, how do you feel about something like Feldenkrais?
About what?
The Feldenkrais or Feldenkrais, the working with you to walk better, without orthotics, without. It's some guy back home who was like selling his thing and making my patient say, "Oh, it's going to be wonderful." And if you've never heard of it,
I
it's
have not
probably
heard of it.
nothing.
Nope.
Okay.
Nope. But I can, I gotta say, I'm dubious. Because you can't think about walking and change your gait through thought. Unless you're working like a professional athlete, they got a trainer there, working with them every day, 8 hours a day. But for most people, it's not something we think about. You learn how to walk when you're 3 or 2 or 1 or whatever, and you don't think about it. You can't successfully, for more than 5 or 10 minutes, alter your gait just by thinking about it. It's so rare to be able to do that. Very few individuals can do that.
Hi, I went to the University of Minnesota for my bunions, and what got my attention is that you said about the big toe for the dorsiflex. Well, they fused my big toe
For a bunion?
for both my bunions, and they said that I asked him, I said, I plank, I run, I downhill ski. He said I'll be able to do all that except for wear heels. Well, guess what? I can't plank, I can't do Pilates, I can't. but why would
Can
they-
you run?
I can waddle pretty
Yeah.
fast.
Yeah, I feel for you. That's an important joint. Fusions. I've done fusions, and when you have a severely destroyed arthritic joint, and you got no cartilage left, and it's painful every step. Again, I talked about reconstructive versus destructive surgeries. The perfect example. A bunion, typically, it's a problem with alignment and where things are sitting, so you can do reconstructive procedures the vast majority of the time and get things back into place and have them work fairly well. Now, anybody who has a bunion has a biomechanical issue and needs orthotics, period. End of story. Anybody else?
What custom orthotic lab do you use?
Kevin Root Labs. They are the best in the country. I've used 15 different labs. I am so particular. My prescription for orthotics takes 3 to 4 pages, but they handle it like pros. They're wonderful. Kevin Root Labs. Kevin-Root. Jeff Root and the Root family were kind of the pioneers of biomechanics, and Kevin Rosenblum and they joined forces, and wonderful, wonderful lab. I won't use anybody else at this point.
Are they in Minneapolis?
No, they're based out of California. I mean, we ship things. Nobody drops them off. Anybody else?
Hi. Could you tell us what are some of your the regenerative techniques?
I've done a lot of amniotic fluid injections. Unbelievable. Wonderful technology. Oh, man. Now, for a while, the government said, yeah, this is great. We're approving this. This is a covered service. And a lot of doctors started using it and like, oh, my goodness, this is phenomenal. And I know doctors who did 30, 40, 50 of these injections, and then the federal government comes a few years later and said, whoops, we're retroactively rescinding this coverage. Give us the money back. Thousands, hundreds of thousands of dollars. How do they do this? It's they're called take-backs or clawbacks. Disgusting, pitiful. I mean, okay, fine, you want to no longer cover it, okay. But retroactively? When you said it was a covered service? Unbelievable. Pitiful. Oh, I'm sorry. Prolotherapy. Prolotherapy has been around for 80 years before we even knew what regenerative medicine was. And that's where you're injecting a substance It's not a drug. Again, regenerative medicine doesn't use drugs. A naturally occurring substance which acts to stimulate acute inflammation, because that's part of healing. And so very inexpensive. Yeah, you got to get a shot. And a lot of these techniques require multiple administrations. So prolotherapy, a minimum is 3. But there's not a drug. There's no complications. You're not going to hurt anything. But very effective. It varies a lot how many injections you're going to give, and it's not a cure for everything, but I've had excellent success with Prolo, and it's inexpensive. And now the amniotic products, there are still manufacturers, but it's entirely out of pocket, and these are expensive, really expensive products. So, but shockwave is considered a form of regenerative medicine. Stimulating stem cells. Stem cells are the holy grail of regenerative medicine. And someday, if we are able to manufacture stem cells, get rid of all, there's so many drugs should get rid of. So, anybody else? Nope. Oh, yeah.
Okay, so you've found your skilled podiatrist and you get your feet properly casted for your orthotics you've been waiting for. How do you know if you've got truly custom orthotics or those made from the so-called
shells,
library?
Yeah. You look on the bottom, and it will have this embossed stamp in it on the bottom. Now, typically, most orthotics come with covers or padding on top. You can't see the shell of the device. But if you look in the bottom, I'll take a look at your orthotics if you want. I'll see what you got. But often it's a true custom orthotic. But if their casting skills aren't good, you're not going to get a good orthotic. So important. Critically important. Yeah.
What about treatment for hallux rigidus?
Do I need to say?
If
Good orthotics. But no, that's just a way to improve their biomechanics. Now, there are people with the alignment or function of the first metatarsal is bad enough or rigid enough that reconstructive surgery can save the joint. So that's something I do encourage with certain people. But the majority of the time, we can get things working healthy and get stress off the joint with Achilles stretches, of course, and properly prescribed foot orthotics.
If I understand you correctly, an orthotic is really a cast to help the body's physicalness structurally change. I completely understand when you have an incredible foot deformity that you might need that cast in a sense as an assistive device. In my experience, we see a lot of people who spend a lot of money, $750, $1,000, whatever. They get that custom orthotic, and they put it into their sneaker, their shoe, their whatever else. And 10 years later, they're still wearing that custom orthotic because they are attached to it financially. I can see that the orthopedic world is moving away from really hard casting for broken arms and stuff like that, because they reckon that it's a splint or a brace or cast for a little bit of time before that bone or whatever heals into a sort of new way. Do you think that in the future custom orthotic will actually be more flexible, more part-time solutions? For example, when you do plantar fasciitis, does it actually go away after a couple of weeks if you're wearing your orthotic properly?
Who said a couple of weeks? You said it, not me. You said it would go away. I didn't give you a time. Everybody's different. And no, the answer is no. Because unless you have your skeletal structure, your ligamentous structure and function, the tendons altered surgically, why would you not still need the orthotic? Are you going to be able to get rid of those eyeglasses if you wear them a couple years? It's the same. How is it different? You've got a problem with your lenses. You can't see well. Add some glasses. Are you going to wear glasses for a year and stop using them? No. This is a part of weight bearing on the planet, and we've got gravity to deal with. Deal with it.
Thank you, Dr. McLean. That is fantastic. He has earned his stripes today.
Thank you.
Fantastic. Before you go we found extra gifts.
So Rotatool downstairs actually had 4 gift certificates for $50 each. And so Shirley went and dug up the rest of the, the names. So would you pick one? So one of them goes to Mary Robertson. Another goes to Raylyn Christians. Corinne, Wagman. And last but not least, Elizabeth Boda. Woohoo! All right, so they're up here. Come get them. Go take a break, about 15 minutes or so, and we'll have a last little bit of time. She's still down there, so go and whatever.